small, but not as
Hi, welcome everybody. It is Friday, May 22nd, House Healthcare. So we're going to start with Legislative Council. They're going to walk us through an amendment to S-190 that House Appropriations did yesterday. And then we can hear from the reporter of the amendment. And I'll just say that a lot of this language is going to seem really, really familiar to everybody.
Good morning, Jen Carvey from the Office of Legislative Counsel. This amendment to S-190 from the Committee on Appropriations combines two provisions of language that you have seen before. One of them is the proposal that we looked at from Representative Black earlier this week, last week, I don't, it's all one together. But several members of this committee signed on to that was framed as a floor amendment. And then it also pulls in a piece of language we looked at several months ago in H-585 and in your budget memo around authorizing an application for a reinsurance waiver, a Section 1332 waiver from the federal government. So that's what we're going to see in here. There are a few instances of amendments, so they're not doing a strike all. They are just amending certain parts of the bill. So the first is striking out Section 2. That was if you remember, the bill you passed out of here was setting limitations on hospital reimbursements for the qualified health benefit plans and the VHI plans. And it talked about 3.5% of a specific set of commercial net patient revenue from non-critical access, non-Medicare dependent hospitals for fiscal year 27, and then setting a 300% Medicare benchmark for fiscal year 2028 and 250% for 2029. And the proposal that we had looked at would have struck that, and that's what this still does, and instead just put in a session law provision, so not amending the statute permanently, for hospital fiscal year 2027, pulling in some definitions, having this applicable to all hospitals, and saying that for hospital fiscal year 2027, notwithstanding the rulemaking requirement generally for rate setting, including reference-based pricing, for hospital fiscal year 2027, the Green Mountain Care Board may order hospitals to reduce their commercial reimbursement rates for the QHPs and the VHI plans based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans, and directing the payers not to reimburse more than that, and including language saying no balance billing. And if a hospital is directed to reduce its rates more than the amount achieved by those directed reductions to the QHPs and VHI plans, then start by targeting rates that exceed 500% of Medicare. This again is most of this, the rest of this was in the bill as you passed it out, but because it strikes out Section 2 and puts in a new one, it incorporates these provisions. And then that language directing the Green Mountain Care Board and Department of Financial Regulation as they're reviewing the proposed premium rates for the qualified health plans and for the VHI plans, that they make sure that those limitations on reimbursements are appropriately reflected in those premiums. Then it strikes out that language that had gone in late in our process in this committee that would have changed the cap on hospital outpatient drugs administered or hospital prices for drugs administered in an outpatient setting that is currently capped at 120% of the average sales price. It was going to increase that cap to 130% of the average sales price, which was needed to make some numbers work. This is striking out that change. So it would keep the 120% cap that is currently in place that was added by last year's Act 55. And then before I show you this piece, the last piece of the amendment that you'll see coming up that we had looked at the other day just made the effective dates consistent with those changes. There had been some additional language required in the effective dates to reflect the Section 3 provision And so that was coming in. You'll see that, but it's number four, it's the fourth instance. So the third instance is what is new to the bill, but not new to this committee or to this year's legislation. And this is moving the provision from the budget bill into this bill for the authorization to pursue the section 1332 waiver and authorizing the Department of Vermont Health Access in consultation with the Department of Financial Regulation to submit a state innovation waiver pursuant to section 1332 of the Affordable Care Act to establish a reinsurance program and seek federal pass-through funding of the advanced premium tax credits as permitted under the waiver provisions. And then fourth, you see the effective date change.
Can you just review for me again, went by fast, what you were saying about the 120% cap?
Yeah, so if you remember in the bill that you passed out of this committee, section 3 of that bill, and we can pull it up and look at that if that's helpful, but section 3 of that bill was going to change that cap from 120% of average sale of annual, average sales price to 130%.
Right.
This amendment strikes that out.
The whole
Strikes out
cap.
that change. No, it
Just
just strikes out the change. So
Okay.
it keeps the status quo of 120%.
Okay, thank you. And that section is in what?
So that is the second instance of amendment in
In the
here.
striking out when
And it says,
strike
yep,
out.
by striking out section 3 in its entirety. So that means we're just not amending 18 VSA 9407. We would not be amending 18 VSA 9407 and leaving it as it currently exists in the statute.
That's what confused me about deleting. So what's deleted,
Section 3 of the bill is deleted.
but it reverts back to what was the 120%.
Right, it keeps the status quo.
Thank you.
Yes. That's why I try to use deleted when language is coming out of a bill as opposed to repealed, which is when a law is going away.
Any questions before we have Representative Wilson? And then after Representative Dickinson comes up, I wanted to talk more. This amendment in this committee was put in quite quickly, and I know we didn't really have time to sort of look at it or talk about it very much, mainly because Ways and Means was taking it up in like the next hour. And so I was really trying to straw pull it quite quickly, and I don't think we had this discussion, but there are some things I wanted to say about it.
And I want to explain the process piece a little bit of why this is coming from the appropriations committee, if that's helpful.
Yeah, that would be really helpful.
So yesterday, Representative Black and I were in House Appropriations. They had a long conversation about the bill. There was, I think, when it came time for them to vote, they were interested in, and they were proposing, their chair proposed adding the reinsurance piece. So that was going to be going in as their amendment. But there was, it sounded like more interest in the bill as a whole if it had the language in it that was what we're calling the Representative Black, several members of this committee amendment, than taking a position on the bill as it came out of this committee with the fiscal years 27, 28, and 29 in the legislation, and then waiting and then reporting a vote on that on the floor, and then having the amendment be proposed and hoping that the amendment that they supported more than I think they were interested in the bill as it came out of this committee would pass. And so I said, so they said, how do we do these votes? And I said, well, one option would be just to incorporate the proposal into as your committee amendment along with the reinsurance piece. And then you can vote on the amendment as you would like to see the bill go to the floor. And there was support for that. And they took a vote, and they voted at 11-0.
11-0.
So that's how it came to be in this amendment and coming from the Appropriations Committee.
Yeah, and I will not be introducing the original Black amendment because there's no reason to, because that would be really confusing on the floor. I think the only change was you put in Green Mountain Care Board instead of board.
Board. And I said, you know what, while I'm in here, I would really prefer it. It really said Green Mountain Care Board, and so I did make that change, but otherwise it is identical.
So I think I would have to make the argument on the floor to floor of, I don't want Green Mountain Care in the.
I would like it to be implied. not-
Yes. Thank you, Jen. Really appreciate it. Representative Dickinson? You all are much more formal in appropriations. I keep wanting to call you Lynn because we all call each other by our first name.
Oh, yeah.
I appreciate your,
Yes, I always have a hard time being appropriate, a little formal. In our committee, we always start with a joke.
yeah, Nolan is. Have I? Can you?
Well, I have a rumor that the good news is that we're going to finish up today. The bad news is that probably not. We'll probably come back next week, but anyway. Yes, so we've had this bill brought to us. And we had this amendment that was presented as well as the bill. I would say that there probably was a certain amount of skepticism about some of it, but when we went through the discussion, we decided that that there were pieces and part, I mean, of course, it goes without saying, our hospital administrators, I would say statewide, don't like this at all. I've heard that 250 is going to put them in wreck and ruin, and, you know, that's probably somewhat true. But what we do have is we have a way to try to save money. This is the goal here. And so one of the things that really occurs to me, and I think in discussion, I've learned a lot in the past 24 hours since we had this week vote. The Green Mountain Care Board already has all this authority. This is not new. They have it. We gave them $1.6 million last year in a bill, and they hired 2 positions to go and do this kind of work, starting with the pharmaceuticals, but also to do this. And this was introduced as something they had to do. It has taken until just recently where they finally hired the contractor, and someone in our committee said yesterday, I think it was from the Green Mountain Care Board, that they will be doing this by July. But the rules are not even started yet. So that's number one. One of the concerns is that these carve-outs, I did talk to some other people, including people in the administration, and their concerns is that they had hoped the savings, and there may not be any savings. I mean, let's be really honest. We don't know if there's going to be savings or not. But their savings was they hope to put across all the ratepayers to carve out just the Health Connect people, which is the people who receive subsidies, and the small employers, the small business group, and the teachers' healthcare plan is that money will not go to everyone. That will go to the Green Mountain Care Board, and they will go and that will only save money for the Health Connect people and the teachers. It will not be something that we can have for the other broad 60% of our ratepayers. So their concern is that it isn't real. They don't really like the bill. One of the reasons that we voted for it was that it just brought it down to a 1-year event. It doesn't dictate what kind of percentage you're going to have like it was in the original bill. And if you feel like I called it like a pilot project, but it gives you 1 year to see if the thing works. It gives a deadline. I think really you have to do it for this coming year and get it done for the Green Mountain Care Board. And then it can be reevaluated next year. And then you can sit down. And again, the hospital will get a chance to see how it affects them. They'll go through the budget process in August and see how this works for their 27 budget. So one of the concerns is that if the governor doesn't like it, and I'm not sure how much he doesn't like it, but he doesn't like it, if there is a chance of a veto in the part that we put in our amendment, which was the creation of 4A for the reinsurance authorization. There's a 1332 waiver that we would have to pursue to get back. Apparently it's used by other states to buy reinsurance to help with their premiums. The issue is that if it's taken out of the big bill, which is where it is now, that was the logic why we saw it, is it doesn't cost us any money. It's already in the big bill. We'll put it into this bill. It'll go through with this bill. But if this bill doesn't go through, then we lose that opportunity. And that was where the governor really hoped to be able to go and get some savings and put the savings that we have into the bill, into the process here. So I'm going to suggest to our chair, who is now doing conference committee on the big bill, that we take and duplicate this language and put it back in the big bill. You can keep it in this bill. And you can put it in the big bill. We've done that all the time with duplicate language, multiple bills, so that it goes through. And that way it'll be in the appropriations bill as well. We'll see how it all sort of sugars off. The chair did tell us that this was a very quick amendment. You had very little time to vote on it. I've had comments made that it was sort of like done in the middle of the night and brought in, boom, and then it was like you had to get it right out. Which is something we do actually in appropriations all the time. People bring in bills, we look at it, and we all go, well, what about this thing here? You know, and of course, you never get a chance to really discuss it that much. So, but that isn't really, you know, you can have things that you didn't intend when you do that. So here we are. But that was our appropriation amendment. We decided to put it together. My understanding, when I spoke to the chairman, your chairman here yesterday, is that I will yield to her and she'll go through the section 2 pieces, and then she'll yield back to me and I'll do the third instance of amendment.
Thank you. Any questions for Representative Dick? Oh, go ahead, DC.
This may be a question for someone at this table, actually. Maybe you know. Is a bill the only mechanism, or is it a required mechanism for authorizing a 1332 waiver?
Well, we probably have to authorize it. Yes, I think we do. I don't know. We authorize the 1115, the global commitment waiver. Periodically. That's a different kind of waiver. That's our global commitment for Medicaid. This would be a different, we've never applied for 1332. We've never applied for 1332. And of course, you know, you may not get it. You apply, you have to meet with. But I do believe we authorize all kinds of things. And that's probably one of them. Executive order would be maybe the way the governor would do it, but I don't know if that would.
No.
Yeah.
Um,
And Nolan, what's the 1332 do anyway?
so I was wondering,
I'm good with that. I'm familiar with the waiver. I just wanted to know that mechanism was there for a reason.
yeah, I think I wanted Nolan to, from a joint fiscal perspective, just sort of talk about like the timing of 1332 and kind of the mechanism of.
So, and I weigh in
Yeah,
briefly, and then
of
I
course.
have to have much more to say.
Okay.
Jenny Parker, Office Legislative Council. So, the 1115 waiver is statutorily required under Vermont law to receive legislative approval before. I believe, but I am not positive, although the healthcare advocate may also know, but often for federal waivers, there is a requirement that the legislature either authorize or somehow affirmatively indicate that they are supportive. I don't believe the governor can do it through executive order alone, because he doesn't have the ability to commit the state dollar. There'd be state dollars required for the 1332 for the reinsurance waiver. And so typically the federal government wants some indication from the legislature that there will be funds for kind of that.
Thank you. That makes sense.
Look to, I don't know if others have more information on that. We haven't applied for one, so I have never.
I'm not sure that has been the case.
So there would be funds for 1332 waiver, state funds?
Yes, we would be for a reinsurance waiver, I believe, I'm going to the Vermont Care Board, I think is some information on that as well, but I think we are all under the understanding that yes, state funds are required for a reinsurance waiver. You can see.
Could I ask, do we know how much funds are required from the state?
Depends
Depends on what?
on what you apply.
For the reinsurance, I mean,
For reinsurance. Yeah,
it's tied to.
there'll be an estimate in one of the reports that for the record, no one will this spot. I don't have the report in front of me, but I remember the number was in the millions.
Tens of millions
I
or?
don't know what you're doing. Again, like, I don't want to say like, it's like saying, well, how much a single parent cost? Like, depends on what you want to do.
Totally get it.
So I think.
But just to give us a,
The idea is that you're going to get in the game, and reinsurance program is going to be tens of millions of dollars of pass through, so you're likely going to have millions of dollars of state requirement. Again, depending on what it is you want, how much you want to reinsure, which products and programs you want to reinsure. But it's not gonna be little money, it'll be big money.
How does have the determination of what products and programs get reinsured? Who decides that?
We do.
The state, the legislature does.
We decide what we wanna do and then we apply for it, and the feds say yes or no.
So it doesn't come out of DFR, or they give us data, but it comes from us.
Again, depending on how, we could pass legislation directing AHS to come up with a plan, or we might design a plan and. Again, it depends on how we design it, but ultimately it would be the executive branch that would be the ones. Applying for it and seeing it through, we would just be the one directing to do it. How much guidance we give them depends on us.
So if DIVA applies, or we're authorizing DIVA with DFR to apply, but it doesn't mean if we get it, we have to pursue it, or what's in the application? What commitment, let's say, is in the application?
And it's a great question. Yeah. I think that's all remaining to be seen. I think that we would apply for it, and then in the process, we would have to determine how much state money we have to put in. Again, the timing of it depends. We might not have, it might not be an appropriation for fiscal year 28 or 29, depending on. But I think that from everything that I've read about it, and again, it depends on how you apply it, there would be some state dollar expectation.
And I have confirmed that federal law and guidance require state legislative authorization for both the waiver and of the insurance program. So yes, we need legislation to authorize pursuit of the waiver.
Let me just say, I don't think I identified myself.
Oh.
But anyway, yeah, no, Representative Lynn Dickinson from St. Albans County Appropriations. Basically, all this does in 4A is it authorizes in consultation with the Department of Financial. It says DIVA in consultation with the Department of Financial is authorized to submit a state innovation adjusted base rate specified by the Green Mountain Care Board for any item provided service delivered in Vermont. The point of it is I think there's no money in this. There was no money intended to be in this. This is just setting up the language because it was in the language section of the big bill. And it's only setting up the authorization so that we have the ability to be able to ask for a 1332 waiver for a reinsurance program. And I believe, and I could get this wrong, but in the brief conversation I had about this with the administration is they are hoping the savings that we get would be one of the sources of whatever money goes into this. And I'm not sure how the reinsurance, we didn't hear anything about how that works, but it seems like it would be a backup to your other, maybe to keep rates down or something.
Yeah, right. It's back up. It's a big thing. Right? Okay. There's no money required to apply for the waiver.
But we want the authorization. So I'm going to ask that it be put back in the big bill as well as in this bill so that it doesn't get lost if for some reason this doesn't work.
Thank you.
Yeah.
Any other questions for Representative Dickinson?
Thank you.
Thank you.
Okay, thank you.
I see you on the floor later.
Yes,
I'm from Essex,
yes.
so
I knew the representative from someplace.
don't say Essex Junction.
No.
No, I know, city versus state.
You get it.
All right, so, I think I wanted to, like I said, this came up very quickly last week. And I wanted to be, I want to be really transparent about how it came about. And I think I talked about this a lot in here, is that, since the beginning of this session, there has been a really robust stakeholder group. And it has included the administration on multiple levels, the Green Mountain Care Board, insurance companies, hospitals association, the Senate, House, just this conversation around, kind of what, because we are at this inflection point right now, we're seeing hospitals really, really struggling. We're seeing the QHP market being eroded. And, we're trying to make this balance of affordability, sustainability. And so like lots of ideas have been thrown out. And this bill started as essentially, because of the RFP process to get a contractor and then to have to go through the rulemaking process, the requirement that we had in Act 68 from last year to start reference-based pricing by October. That's what this bill started. And then as the bill worked its way through the Senate and it came over to the House, all these working groups, I can't tell you the number of people that have been like running numbers. And the bill just sort of kept morphing into, well, how much is this? And how much can we afford to take from here? And what would the percentage here and be equivalent to? And, then you make a call to an actuary and then they get back to you and then the numbers change. And it's been like trying to hone in on this process. And that was the bill that we passed out of here. And we passed that bill out of here because numbers were changing rapidly and everybody was involved in it. And so it got down to the very end after we passed it out of here. And then there was a concern that we weren't sort of making it explicit that this was the dollar amount. And the reason I offered this amendment was because the bill stopped becoming about reference-based pricing and what we were trying to do to help Vermonters. And it became the legislature involving itself and requiring what hospital budget orders were going to be for this fiscal year. This is a process that is in statute, in rule. This is a process that works and has been working for 14 years now? 14 years. I encourage anyone this summer, if you want to spend some time watching on YouTube, to watch, the whole budget process. It starts in, is it March or February? March, where the Green Mountain Care Board puts out guidance to the hospitals so that the hospitals can come in August or July.
Their budgets come in July 1st and then we review them for
Yeah.
the subsequent.
So they've got guidance from the Green Mountain Care Board in March. They present their budgets that hopefully meet the guidance. And then they go through this lengthy process of review with each hospital. And then at the end of it, Green Mountain Care Board makes their final orders based upon all the information that they have gathered and questions that they've asked, and the healthcare advocate has asked, public comment has asked, and it's a really robust process. And this process has been working really well. I mean, others would disagree. There's always going to be tension between a regulator and who's being regulated. That's kind of the beauty of the system, is that there should be tension and it's a negotiation back and forth and accurate information is given back and forth. And I just got to the point in this bill where I thought, oh my gosh, we, the legislature, are stepping in for the next 3 years and trying to dictate this process, which frankly would derail what the process really is about. So I worked with Ledge Council to sort of supplant all those prescriptive. I mean, it was getting really confusing. It was 3.5, and then it was 3, and then it was 4, and then there was 250%, 300% this year. And we have tasked Green Mountain Care Board with hospital budget regulation. We have tasked And they are really good at it. They have incredible expertise, as do the hospitals. We have tasked them with reference-based pricing. They have got contract, they have the employees hired, they are working diligently, they're trying to get through the rulemaking process. It's a very long process. And they also regulate the QHP market as far as rate setting goes. So they're trying to make this balance. And so the amendment is really removing the legislature from the prescription of what the Green Mountain Care Board already does. And it is allowing the Green Mountain Care Board to make these decisions, and more importantly, to make these decisions on an individual hospital level. That's one of the things that we ended up doing in the original version of the bill, was we sort of made this one size fits all for all the hospitals. And that's not how the budget process works. You know, there's guidance, but hey, UVM has guidance that's lower than everybody else's. I think Northwest Medical Center has higher than everybody else this year. And that's just their target. And this will allow the Green Mountain Care Board to tailor make this reference-based pricing for these vulnerable markets that will help taxpayers. And allow them to adjust and make it for each hospital. Let's not forget, Green Mountain Care Board is tasked with hospital sustainability. They must follow the principles of Act 48. That is their charge. That's why I introduced this amendment. I don't think I got enough. I think I wasn't able to give enough time to sort of explain where this came from and what I was trying to do with this. I think that what I'm trying to do with this is that the intent of the legislature is we talked from day one. We went around this table and we said, what is most important to you this session? And every last one of us said, affordability for Vermonters, affordability for Vermonters. And that is what this bill first and foremost is. It is a reference-based pricing bill, and it addresses affordability for Vermonters. Unlike any other bill that we have done in this committee this whole year, this is the bill that we are saying this was our number one priority, and this is what we're doing. Okay, there. And I cried in appropriations yesterday. Any comment before I take a straw poll on this?
Can I make a comment? I think a lot of it is the messaging on this, like even with Representative Dickinson, when she was in here saying that it felt like it was going too far, and then she kind of said that the governor thought it wasn't going far enough. Like, I think that we're missing some messaging here. By saying that, like, not having VSCA in there either, that
What?
Actually, can I address that concern?
Yes.
Because I told you, there's been a very robust stakeholder. Numbers were run for all markets. Numbers were run from across. The amount of money that the hospitals have committed to in savings this year, when that was extrapolated across the entire commercial market, it was so de minimis to having any effect on premiums that frankly, nobody would have noticed it. And the reason it came down to the two markets that are in here, the QHP market and the VHI, is that those are the rates the Green Mountain Care Board is actually, able to set. If you look at 40% of the commercial market, which is what, the DFR is concerned about, which Representative Dickinson was referring to, that is all self-insured. And those are third-party administrators. We don't we don't have any say in what the rates are to their customers, their employers. I mean, they are, yes, a lot of it is Blue Cross Blue Shield. I understand that. It's also a big chunk of it is Cigna Healthcare. There is a big chunk of it that is United Healthcare. And I'm not that I don't care about every employer and every Vermonter, but if I have the opportunity to help the most, I'm going to help the market that I can ensure or that we can ensure is actually going to see their rates come down. As opposed to, I am loath to give Cigna Healthcare more money for their shareholders.
I'm in total agreement with where this is going right now.
That was why it ended the way it ended.
I love where it ended, and I'm not saying, I'm just talking about the messaging that's, we're hearing someone say it's not going far enough, and then we're hearing other people say it's going too far, we're gonna fill the hospitals. That was part of my messaging, or the messaging part of it. Other part, like, build it down. And it all has to do with. I'll come up with it, someone else go. I love this stuff. I'm just gonna say, I think it is very impactful. Last year it was 68, during this, I really believe that what we're doing here is probably the most impactful as far as savings to want this money on. Okay, I love this. That's all I have to say.
Would anyone like a preview of my bill report?
We have 10.
Okay, oh,
Yeah.
we do. Oh, I didn't realize what time it was.
Yeah.
We're until at 10.
Do,
Oh,
give a show.
I'm just like, there are 4 really important parts of this bill. And number 4 is this bill actually will help hospitals. Financial pressures, here, I think.
Do it.
Pretty good preview. The financial pressures that Vermont hospitals face are real, but the diagnosis matters. UVM MC's losses, which Steve Leffler sat in here, as described by CEO Steve Leffler, stemmed primarily from reduced utilization, not from insufficient commercial rates.
I love that you said that.
The utilization problem will get worse, not better, if we allow the QHP market to keep shrinking. When Vermonters can't afford coverage or downgrade to high deductible bronze plans, they skip care. That means fewer paying patients, more bad debt, and more charity care. The exact conditions further strain hospital finances. That is what is hurting all of Vermont hospitals, not just UVM. Yeah.
I
That's what
love that
said.
you did that.
So, I mean, that's my reasoning behind,
Is this the first bill on the floor?
I think so. I hope not.
I thought it was the first one on the calendar, but
Probably this afternoon.
This afternoon. Okay, any other discussion? I didn't realize we have to get to the floor.
No, forensic facilities.
Okay.
Make a motion that we approve.
Yeah.
Do we need a motion?
No, don't need a motion, just a
Straw
straw poll. All those approve of the House appropriations amendment to S 190, please raise your hand. 1, 2, 3, 4, 5, 6, 7. Opposed? 4, 7, 4, 0. All right. I will report that out.
Your second up.
For just, do we have anything else on the floor today? Do we have the committee of conference report on 8/16? Is that been signed?
yes.
Yeah, we signed it.
Is that on our notice calendar?
Have to look.
I didn't see it either.
I'm sorry.
And now my phone's on.
I'm not sure of that. Do we have to approve? Do we have to straw poll the committee of conference report?
I don't think anyone has any control over that.
Okay.
I would ask the lawyer.
Lord, for no.
And do we have 8/17 on the notice calendar? That was, I know that's not one of your bills, Jen.
But do we get to see the committee of council support or?
It was a secret and it gets hidden in the state archives for
Oh, we're
100
done.
years.
I think
I mean,
for the day.
Actually, that's
Go to
64.
the
We'll
floor.
come to the floor today.
Be reported on the floor.
We consider it on the floor.
All right.
It's on the
You
webpage.
can go off of like
Actually.